Today we are going to have a discussion on the clinical identification of the likely cause in order to make the provisional diagnosis. Now we all are aware of the fact that these are the potential causes of the burning abdomen, but as a MBBS graduate, at least you should be knowing about the possible reason behind despite having all the investigations. That how clinically these causes are different from each other in order to make the provisional diagnosis. So for that we are having a first question. A 42-year-old male presents to the outpatient department with the 3-month history of burning sensations in the upper abdomen that is worst on the empty stomach and often wakes him at night. Now, this obviously is the first clue, which is not common in all the causes of the burning sensations of the abdomen. The second one is that there is a reporting of the pain which is partially relieved by eating food or taking antacids, because this thing the patient has already experimented with. Third is that there is no weight loss, there is no history of vomiting, but he occasionally feels bloated after meal. This is the third hint which is provided to you in the question, which also is helpful in ruling out the other options. Now, very importantly, he is a chronic smoker and takes non-steroidal anti-inflammatory drugs regularly for the chronic knee pain. That is point number 4, which attributes or which is responsible for contributory, which is acting as a contributory factor for specific sorts of the ulcers. Now, on examination, there is mild tenderness in the epigastric region, but no guarding or rebound tenderness. That is point number 5 or the hint number 5. And finally, basic blood investigations like CBC, LFT, RFT, they are all normal. That is point number 6. Which of the following is the most likely diagnosis? As you can see, there is no specific finding which is mentioned in this question. All you have to do is to identify the provisional reasons for these kind of the ulcers based on the clinical features provided, and this is exactly what we are talking about, that how the different type of the common ulcers or the common reasons for the burning sensations in the abdomen presents with clinically, and how will you identify it. Now if you look at option wise, now the option A obviously is the gastroesophageal reflux disease. How the question related to GERD would be presented, there will be a burning retrosternal pain, not the epigastric like it is provided to you in the question. So that is point number 1. This is how it can be ruled out. Now, another feature of this GERD is that it is worst on lying down, particularly after meals, because of the reflux of the contents from the gastric into the esophagus. So that is the reason why this feature obviously is not provided to you in the options. So this GERD can be ruled out. Now, in case of GERD, there has to be a feature provision of the acid regurgitation. That means sour taste, the feeling of the sour taste that comes occasionally because of this GERD disease, which also is not provided to you in the question. And there is no relief by eating food. Actually, it is worsening, or the pain worsens when there is a history of burning sensations related to food. So obviously, why is it wrong here? Because in the patient over here in the question, the patient is having a epigastric pain, not the retrosternal. It is worst on the empty stomach, not postprandial, and the pain is relieved by food, not typical of GERD. So that is why GERD is unlikely as a option. Now, the second option provided to you in the question is that of the gastric carcinoma. You should be remembering about what are the red flag features of the gastric carcinoma. That means high risk features of the gastric carcinoma, which obviously would have been provided to you in the question. Now, age more than 50, there in the question, age is 42. Unintentional weight loss, but it is not provided to you in the question. Specifically, it is mentioned that there is no weight loss. You see, in the question itself, it has been provided that there is no weight loss and there is no vomiting. So, this red flag sign related to the gastric carcinoma is also not there. Now, early satiety, the history of hematemesis or melena, refractory symptoms despite the management, and systemic symptoms related to anemia and fatigue would have been provided had this question been asked in relation to the gastric carcinoma. So these are the red flag features that you should be knowing about in order to identify the questions related to gastric carcinoma. And then finally, the option D, that is functional dyspepsia, which is common in case of young patients presenting with the normal endoscopic findings and investigations, and often presents with the vague symptoms like bloating, fullness. Not clearly it is related to the food. So in our question, the pain is clearly triggered and it is relieved by food. The patient is having a risk factor which is pointing towards an organic cause like history of smoking, which is mentioned over there in the question. And the patient wakes up at night, which is more typical of the ulcer than that of the functional dysplasia. So functional dysplasia is also less likely. So based on all the information which has been provided to you in our question, if we go back to the question that the pain is relieved by the food and antacids, which is hint number two, is a classical feature for duodenal ulcers. Now, the pain which is worst on empty stomach or night pain, that is feature number one, is a hallmark feature of the duodenal ulcer again. The history of non-steroidal anti-inflammatory drugs is a major risk factor for the duodenal ulcers. The history of smoking is also contributory risk for the development of the duodenal ulcers. And the epigastric tenderness is responsible for localization of the cause to the duodenum or the stomach. So this also goes in the favor of duodenal ulcers. And specifically, they have mentioned that there is no history of weight loss or vomiting and the normal laboratory findings, as a result of which the complicated ulcers can be ruled out. So this is the essence of this question. To some extent, you would be able to identify that how to deal or how to identify the common causes for the ulcers. Now, one very common perception is that how to differentiate in between duodenal and the gastric ulcers. So let's see a quick clinical comparison only without going too much into the explanatory or etiological findings. Like, duodenal ulcer potentially usually are seen in case of younger individuals while gastric in older individuals. The timing which is related to the pain is that it occurs, duodenal ulcer occurs 2 to 3 hours after meals, which is relieved by food, but gastric ulcers are usually associated with the worsening of the pain related with the food intake. As far as nocturnal pain is concerned, it is one clinical feature of the duodenal ulcer which is very, very commonly identified, while in case of gastric ulcer, it is less common. The weight loss is usually absent, but it is often present because gastric ulcers commonly could also be associated with the cancers. Risk factor, the NSAIDs, the H. pylori, and the smoking for duodenal ulcer. For gastric ulcer, again, the same, but more importantly, the presence of the malignancy. And whether it is relieved with the antacids or not, yes, quick relief with the antacids in case of uncomplicated duodenal ulcers, but partial or no relief in case of gastric ulcers. So this is how quickly, based on the clinical identification only, the duodenal and the gastric ulcers could be identified. You see, not only the common causes like GERD, the gastritis, the functional dyspepsia, or the duodenal ulcers are the reason for the epigastric pain. There are other reasons also like pancreatitis, but in case of pancreatitis, there has to be a specific feature of epigastric pain which is radiating to back with the elevated enzymes. Carcinoma, there has to be a weight loss, vomiting, and anemia that we have already talked about. In case of biliary colic, there has to be a right upper quadrant pain along with the history of which aggravates after post fatty meal. And in case of neuropathic reasons, there has to be a dermatological pattern or the chronic diabetes history. So these also are the clues in order to reach the diagnosis for these specific causes. So once we have understood everything related to this, now it will become much easier for us to answer the questions related to the cause of the burning sensations in the abdomen and rule the other options out. Like this question, 28-year-old woman presents with the burning sensation in the upper abdomen that occurs intermittently over the past 6 months. Now she describes the discomfort as non-radiating, not related to food, and often associated with bloating and feeling of fullness after eating small amounts. There is no weight loss, vomiting, fever, or NSAID use. Physical examination, routine workup are absolutely normal. Upper GI endoscopy is performed, which was also normal. What is the most likely diagnosis the patient is suffering from? You will already came to know the answer, and the answer for that question is functional dyspepsia. Why? Normal endoscopy, no flex sign, no red flag signs, no postprandial fullness. It is pointing towards the functional. That means non-ulcer dyspepsia. Second is, it is typically diagnosed when no structural abnormality is found, and organic causes like gastritis or ulcers usually have specific triggers like food, non-steroidal anti-inflammatory drugs, the history of H. pylori. So GERD, as you know, that it would have involved the heartburn and acid regurgitation, not the epigastric vague fullness, which is provided to you in the question. So answer for this is functional dyspepsia. Next is a 35-year-old male presenting with the burning sensation behind the sternum that occurs especially after meals and when he lies down at night He often feels a sour taste in the mouth. Now, what else is required for you to reach the diagnosis of the GERD? And sometimes wake up coughing or choking at the night. He denies any history of vomiting, weight loss, or hematemesis. He is otherwise healthy and does not take any medications. What is the next most appropriate management? Answer for that question is prescribe omeprazole and advise lifestyle modifications, because this is the classical case of GERD, which is post meal heartburn, sour taste, nocturnal symptoms. So, empirical triad of the proton pump inhibitors is the first line in majority of the cases. Endoscopy is reserved when there are alarming symptoms or if there is no improvement after the PPI. Coming on to the next question. A 56-year-old man presenting with the burning epigastric pain that started 2 months ago. Now he reports early satiety, unintentional weight loss of 6 kgs and fatigue. Now all of these are pointing towards the red flags of the carcinoma. Now the pain is not relieved by the antacids. He has no history of non-steroidal anti-inflammatory drugs, and the physical examination shows the pallor and the mild epigastric tenderness. CBC reveals microcytic hypochromic anemia. The fecal occult blood test is also positive. That means melena is also positive. So, what is the most appropriate next step in the management? Answer for that question is perform an upper GI endoscopy. Why? Because you have to take the biopsy. Red flag signs are present. Endoscopy is essential for identification of the ulcer or the tumor or the bleeding source. PPI and iron supplements are supportive, but it is usually not the immediate next step in order to manage the patient. So, hopefully, you have understood how the questions could be framed and what should be your approach in order to mark the correct answer related to these. Now, we also are including one topic which is very, very commonly asked, particularly by providing you as a differential diagnosis to the burning epigastric pain sensations. So, if we read the question out, that 45-year-old man presenting with a chronic burning epigastric and pain and persistent diarrhea for the past 6 months. Now, he reports that there are abdominal pain is severe, occurs after meals, and worsens at night. He has been treated with PPI for gastric ulcers, but the symptoms have only partially improved. Endoscopy reveals multiple ulcers in the duodenum and proximal jejunum. Blood tests reveal elevated fasting serum gastrin levels. So, which of the following is the most likely diagnosis? Why this sort of a question is introduced? Because this question is very, very commonly asked. Zollinger-Ellison syndrome, it is caused by gastrinoma. All of you are aware of the fact. And in any question related to this, wherever a clinical question is asked, you have to remember this triad. That is severe peptic ulcers, presence of the diarrhea with a high gastrin level, and ulcer occurs beyond the typical sites, that means duodenum and jejunum. So it may be sporadic or it could be associated with Menman syndrome. So that is why this question is very, very frequently asked. So let us see how to reach the diagnosis by looking at the investigations. The investigations, the initial set of investigations includes the CBC, which is reflective of anemia, which could be because of the chronic blood loss, or leukocytosis, which could be because of the infection. The LFTs, lipase, and amylase to rule out hepatobiliary or the pancreatic cause, because these findings would be elevated in case of pancreatic causes. H. pylori testing for the duodenal ulcers or the gastric ulcers, the stool for the occult bleed for looking in order to look for the GI bleeding. Upper GI endoscopy is the gold standard for the ulcers, gastritis, or the malignancy. Abdominal ultrasonography is for the gallstones or for the masses if there is a possibility, and CT abdomen for the suspected complications. So these are the initial set of investigations. One thing that you should be knowing about that upper GI endoscopy is the gold standard for identification of the ulcers along with this complication. In case of suspected diagnosis like gastrinoma, which is Zollinger-Ellison syndrome, then you have to go for the serum gastrin levels and the secretin levels. In case of GERD with persistent symptoms, you have to go for 24-hour pH monitoring. In case of functional dyspepsia, the diagnosis of exclusion, you have to exclude the other causes. For gastric cancer, biopsy via endoscopy. For diabetic gastropathy, gastric emptying study. So hopefully the session was of help. Hopefully you have understood something new. So the reason why this lecture was taken, that you should be able to provisionally diagnose that what is the likely cause behind this pathology in order to mark the correct answers in future, and you should not jump onto the investigations immediately. Okay, so on the basis of clinical identification, you should be able to diagnose that what is the likely reason for this pain in the epigastric region. So all the best for your future examination. In order not to miss any update, please join our Telegram group. The link is provided to you in the description. Thank you.